Good afternoon, my dear students, and today we're gonna start the hematology part of lectures in internal medicine. And the first topic will be anemias. So let's start. Anemia is best defined in relation to hemoglobin and hematocrit levels below the normal reference range because of patient's symptoms and physiological consequences as a result of decreased oxygen carrying capacity of the blood. According to the World Health Organization criteria, anemia is diagnosed in males when hemoglobin is below 130 gram by deciliter and hematocrit is below 0.39 or 39% of normal ranges. In non-pregnant females, hemoglobin levels below 120 gram by deciliter and hematocrit levels below that 36% is an indication that patient has anemia. Production of red cells or erythropoiesis is tightly regulated process by which hematopoietic stem cells differentiate into erythroid progenitors and then mature into red cells. The mass of circulating erythrocytes constitutes an organ responsible for the transport of oxygen to tissues and removal of carbon dioxide from tissues for exhalation. Collectively, the progenitors, precursors, and adult red cells make up an organ termed the erythron, which arises from pluripotent hematopoietic stem cells. Following commitment to the erythroid lineage, unipotential progenitors mature into the erythroid progenitors, the burst-forming unit erythroid, and subsequently the colony-forming unit erythroid, which then undergoes further maturation to generate enucleate polychromatophilic macrocytes, reticulocytes on supravital staining. The reticulocytes further matures first in the marrow for 2 to 3 days and subsequently in the circulation for approximately 1 day to generate discoid erythrocytes. The Proliteroblasts, the first morphologically recognizable erythroid precursor cells in the marrow, undergoes 4 to 5 mitoses prior to maturation to an orthochromatic erythroblast, which then undergoes nuclear extrusion. In the adult stage of development, the total number of circulating erythrocytes is in a steady state, unless perturbed by a pathological or an environmental insult. The anatomical unit of erythropoiesis is in the normal adult person is the erythroblastic island or islet. The erythroblastic island consists of centrally located macrophages surrounded by maturing terminally differentiating erythroid cells. Evidence suggests that either the erythroblastic islands migrate or that erythroid precursors move from island to island, as islands near sinusoids are composed of more mature erythroblasts, while islands more distant from the sinusoids are composed of proerythroblasts. As the erythroblast matures, it moves along a cytoplasmic extension of the macrophage away from the main body. When the erythroblast is sufficiently mature for nuclear expulsion, the erythroblast makes contact with an endothelial cell, passes through a pore in the cytoplasm of the endothelial cell, and enters the circulation as polychromatophilic macrocyte or reticulocyte. The nucleus is ejected prior to egress the marrow, phagocyted, and degraded by marrow macrophages. The macrophage of the erythroblastic island appear to play a stimulatory role in erythropoiesis independent of erythropoietin. Also perform other functions, including rapid phagocytosis of extruded nuclei as a result of exposure of phosphatidylestyrene of the surface of the membrane surrounding the nucleus. A progenitor in the hematopoietic system is defined as a marrow cell that is a derivative of the pluripotent hematopoietic stem cells through the process of differentiation and is antecedent to a precursor cell, the later being identifiable by the light microscopy by its morphological characteristics. In erythropoiesis, the earliest precursor is the proerythroblast. Progenitor cell also may be identified by characteristic profiles of the surface CD antigens using the flow cytometry. The high concentration of polyribosomes gives the cytoplasm of these cells its characteristic intense basophilia. Basophilic erythroblast is more than proerythroblast. The nucleus occupies 3/4 of the cell area and is composed of characteristic dark violet heterochromatin, interspersed with the pink staining clumps of eochromatin linked by irregular strands. Following the mitotic division of the basophilic erythroblast, the cytoplasm changes from deep blue to gray as hemoglobin dilutes the polyribosome's content. Cells at this stage are smaller than basophilic erythroblast. The nucleus occupies less than half of the cell area. Electron microscopy of the polychromatophilic erythroblast reveals increased aggregation of nuclear heterochromatin. After the final mitotic division of the erythropoietic series, the concentration of hemoglobin increases within the erythroblast. Under light microscope, the nucleus appears almost completely dense and featureless. It's measurably decreased in size. The cell is the smallest of the erythroblastic series and has a name, orthochromic erythroblasts. The next station are the sideroblasts. As all normal erythroblasts are sideroblasts in that they contain iron in structure called siderosomes and evident by transmission electron microscope. These structures are essential for the transfer of iron for heme synthesis. Following nuclear extrusion, the reticulocyte contains mitochondria, small numbers of ribosomes, the centriole, and a remnant of the Golgi apparatus. It contains no endoplasmic reticulum. Supravital staining with brilliant crescent blue or new methylene blue produces aggregates of ribosomes, mitochondria, and other cytoplasmic organelles. Maturation of reticulocytes requires 48 to 72 hours. During this period, approximately 20% of the membrane surface area is lost. Stress reticulocytes are released into the circulation during an intense erythropoietin response to acute anemia or experimentally in response to large doses of ecogenously administered erythropoietin. These cells may be twice in normal volume, with a corresponding increase in mean cell hemoglobin content. The physiologic regulator of red cell production, the glycoprotein hormone erythropoietin, is produced and released by peritubular capillary lining cells within the kidney. These cells are highly specialized epithelial-like cells. A small amount of erythropoietin is produced by hepatocytes. The fundamental stimulus for erythropoietin production is the availability of oxygen for the tissue metabolic needs. Erythropoietin acts by binding the specific receptors on the surface of the marrow erythroid precursors, inducing them to proliferate and to mature. The process of making red cells is orchestrated by the complex network of transcription factors. Erythroid cripple-like factor, besides its role in globin gene activation and the switch from the fetal to adult globin gene expression, is required for the last steps of erythroid differentiation, but not proliferation, and directly regulates genes involved in the hemoglobin metabolism and membrane. Stromal and immune cells play an important role by providing factors that include integrins or their ligands and cytokines. These factors are capable of inducing proliferation and survival, which allows the program of differentiation of erythroid progenitors to take place. To ensure a constant production of red cells, various components are required, including iron for hemoglobin synthesis and folic acid and vitamin B12 for DNA synthesis. Insulin growth factor 1 synergizes the other cytokines to increase proliferation of early erythroid progenitors and may coordinate the production of red cells during development of the increase of body mass. Steroid hormones, through their nuclear receptors, may also enhance red cell production, but none of these molecules are involved in the fine regulation of erythropoiesis. Angiotensin II stimulates the proliferation of normal erythroid progenitors, and lack of angiotensin converting enzyme may also cause anemia. The normal resting shape of erythrocytes is a biconcave disc. Normal human red cells have a diameter 7 to 8 nanometers, and the diameter decreases slightly with the cell age. The size decrease likely results from loss of membrane surface area during the erythrocyte lifespan by spleen-facilitated vesiculation. The normal erythrocytes turns reddish-brown with the right-stained blood films and pink with GM's stain. The central third of the cell appears relatively pale compared with the periphery, reflecting its biconcave shape. During its 100 to 120 day lifespan, the red cell travels approximately 250 kilometers and loses approximately up to 20% of its cell surface area. The long survival of the red cells is the least partially a result of the unique capacity of the membrane to tongue thread, that is, to rotate around the cell contents and thereby facilitate more efficient oxygen delivery. The resiliency and fluidity of the membrane to deformation is regulated by the spectrin-based membrane skeleton. The membrane is composed of lipids and proteins, and the interior of the cell contains metabolic machinery designed to sustain the cell through its 120-day lifespan and maintain the integrity of hemoglobin function. The reticulocyte loses membrane as it matures into a discocyte, and membrane loss by vesiculation continues throughout the erythrocyte lifespan. The notion that erythrocyte aging is synonymous with membrane loss and decreasing deformability largely results from the studies on density separated cells and the equating of the dense cells with the age cells. There are many different shapes of erythrocytes. Some of them are natural, some of them can appear in pathophysiological state or diseases. So we will talk about several ones, but during this lecture you can read closely and to see these tables to know more. So for example, bar cell or crenated cell or berry cell, which is called echinocyte, are represented by erythrocytes with short, equally spaced projection over entire surface, progressing from the crenated disc to the crenated sphere with nearly complete loss of the specules. Appear in case of uremia or liver diseases, low potassium red cells, for example, carcinoma of the stomach and bleeding peptic ulcers. Acanthocytes represented by acanthoid cell with irregular speculated projections of a Rhineland position can appear in case of alcoholic liver disease or malabsorptive status. Stromatosite, which is spherotic microspherocyte with dense hemoglobin contents, can in electron microscopy usually shows a persistent minimal dimple, appears in immune hemolytic anemias, hereditary spherocytosis, or post-transfusion problems with different type of fragmentation due to hemolysis. Schistocyte is the cell often represented as a half disc shape with 2 or 3 pointed extremities, may be small, and appear in carcinomatosis, severe burns, or different type of hematolytic anemia, especially secondary to some of inflammatory disorders. Drepanocytes or sickle cell containing polymerized hemoglobin S, showing various shapes, can appear in sickle cell disease, hemoglobin C Harlem hereditary problems. Leptocytes represented by SIN cell or Bayfair cell which is thin, erythrocyte, flat with hemoglobin at the periphery, appears usually in CBC in case of thalassemia or obstructive liver diseases. There are many different shapes of erythrocyte in different disorders, so according to the smear, we can also diagnose some of pathological conditions or at least predispose them. Because hemoglobin accounts for approximately 90% of the dry weight of the erythrocytes, the biosynthesis of hemoglobin is intimately related to erythropoiesis. 3 complex metabolic pathways are required for synthesis of hemoglobin, corresponding to the 3 structural components of hemoglobin: protein, globin, protoporphyrin, and iron. The polypeptide chains of adult hemoglobin themselves are of 2 kinds known as alpha and beta chains, similar in length, but different in amino acid sequence. The alpha chain of the human hemoglobin, embryotic and adult, is the same. The non-alpha chains, including the beta chain of normal adult hemoglobin, the gamma chain of fetal hemoglobin, and the delta chain of hemoglobin A2. At the center of each hem group is the single atom of iron in the ferrous state. Thus, Heme is the metalloporphyrin incidentally responsible for the red color of the blood. The porphyrin ring is wedged into its pocket by phenylamine of its polypeptide chain. The oxygen binding site of hemoglobin is the heme pocket present in each of the 4 polypeptide chains. A single atom of oxygen forms a reversible bond with the ferrous iron of each of these sites. So a molecule of hemoglobin binds 4 oxygen molecules. The product is oxyhemoglobin. The oxygen delivery function of hemoglobin, that its ability to pick up oxygen at the lungs and to release it to the tissue cells, is made possible by minute conformational changes of quaternary structures that occur in the hemoglobin molecule and which alter the affinity of the hem pocket for oxygen. Hemoglobin has 2 quaternary structural sites, the deoxy site and oxy site. A small amount of carbon dioxide is transported from the tissues to the lungs, loosely bound to N-terminal amino acid of the 4 globin polypeptide units of hemoglobin. The product of this combination is carbinohemoglobin. However, the most of carbon dioxide is transported as bicarbonate in the blood plasma. The clinical manifestation of anemia are a function of the degree of tissue hypoxia and the etiology and pathogenesis of the specific anemia. Decreased oxygen carrying capacity mobilize compensatory mechanism designed to prevent or ameliorate tissue hypoxia. Red cells also transport carbon dioxide from tissues to the lungs and help distribute nitric oxide throughout the body, but transport of these gases does not appear to be dependent on concentration of red cells into the blood and is normal in anemic patients. Tissue hypoxia occurs when the pressure of oxygen in the capillaries is too low to provide cells with enough oxygen for cell metabolic needs. In an average person, the red cell mass must provide the total body tissues with approximately 250 milliliters in minute of oxygen to support life. The oxygen carrying capacity of normal blood is 1.34 milliliters per gram of hemoglobin, approximately 200 milliliters by liter of normal blood. The cardiac output is approximately 5,000 milliliters in minutes, thus 1,000 milliliters in minute of oxygen is available at the tissue level. In anemia, extraction of the amount of oxygen leads to hemoglobin saturation and lower oxygen tension at the venous end of the capillary. The resultant hypoxia is an immediate vicinity initiated number of compensatory and frequently symptomatic adjustment in the supply of blood and oxygen. Hypoxia by inducible transcription factor and its homolog with the tissue-restricted expression play a central role in the body response to hypoxia. Its actions include respiratory control, transcriptional regulation of glycolytic enzyme genes, angiogenesis, and energy metabolism. Energy metabolism at the optimal oxygen supply is sustained by energy-efficient oxidative phosphorylation. In hypoxia, energy is produced by less efficient glycolysis accomplished by upregulation of transcription of glycolytic enzymes, genes, and increased glucose transport, a process known for the Pasteur effect. The Pasteur effect and its exception, the metabolism observed in malignant tissue, referred to as the Warburg effect, who was explained at the molecular level by changes of hypoxia-inducible transcription factor 1 levels. Efficient increase in tissue oxygen delivery is accomplished by decreasing the affinity of hemoglobin for oxygen. This action permits increases oxygen extraction from the same amount of hemoglobin. The effects of decreased oxygen carrying capacity of the tissue tension of oxygen can be compensated acutely by increasing tissue perfusion locally via the change in vasomotor activity and in the long run by enhanced tissue angiogenesis. Because in chronic anemia, the blood volume is not changed, increased tissue perfusion and organ selective, accomplished by shunting the blood from non-vital donor tissue areas to oxygen-sensitive essential recipient organs. In acute anemia, the major donor areas for distribution of blood and the mesenteric and iliac beds. In chronic anemia in humans, the donor areas are the cutaneous tissue and the kidneys. Vasoconstriction and oxygen deprivation in the skin cause the characteristic pallor of anemia. In the kidneys, the oxygen supply under normal conditions exceeds oxygen demands. Renal hypoxia must be present to activate hypoxia-inducible transcription factor 2 and stimulate increases erythropoietin production and erythropoiesis. General effects of the hypoxia leads to activation the carotid body, a cluster of specialized cells in the carotid artery, which can have ability to detect low oxygen levels in the blood and alert the brain. In response, the brain sends signals to the rest of the body, which lead to increased breathing rate and constrict vessels in the lungs, increasing the heart rate, dilate peripheral blood vessels in the arm, legs, hands, and feet to improve oxygenation. Increased cardiac output is a metabolically expensive decompensator device. It decreases a fraction of oxygen that must be extracted during each circulation, thereby maintaining high oxygen pressure. Because the viscosity of the blood in the anemia is decreased and selective vascular dilation decreases peripheral resistance, high cardiac output can be maintained without any increase in the blood pressure, and otherwise healthy person, a measurable increase in the resting cardiac output does not occur until hemoglobin concentration is less than 7 grams by deciliter, and clinical signs of cardiac hyperactivity usually are not present until hemoglobin concentration reaches even lower levels. Signs of cardiac hyperactivity include tachycardia, increases arterial and capillary pulsation, and hemodynamic flow murmurs. Murmurs usually are heard during systole. Murmurs and bruits have been described in many regions, such as over the jugular vein, the closed eye, and the parietal region of the skull, and may be sensed by the patient as a roaring in the ears, called also tinnitus, especially at night. They disappear promptly after the hemoglobin concentration is restored to normal. Angina pectoris is high output failure supervene if anemia is so severe that it exceeds myocardial oxygen demands, or if the patient has coronary artery disease. Deficient anemia, significant Anemia leads to a compensatory increase in respiratory rate that decreases the oxygen gradient from ambient air to alveolar air and increases the amount of oxygen available for to oxygenate a greater than normal cardiac output. Consequently, exertional dyspnea and orthopnea are characteristic clinical manifestation of moderate to severe anemia. The most appropriate response to anemia is a compensatory increase of the red cell production, which may increase about twofold to threefold acutely, and fourfold to sixfold chronically, and tenfold in the most extreme cases. The increase is mediated by increasing the production of erythropoietin, and the rate of the erythropoietin synthesis is inversely and logarithmically related to hemoglobin concentration. The change of erythropoietin levels ensures that the red cell production increases in response to hemolytic or other anemias and subacute blood loss. If the former is mild, the anemia may be compensated, and if iron is available, the blood loss will be repaired after it ceased. Augmented erythroid activity expands marrow space, which is, if intense, can cause terminal tenderness and diffuse bone pains. The proportion and number of reticulocytes increase because of erythroid transit time through the marrow is shortened. Stress reticulocytes have increased cell volume and surface area. A certain residual degree of tissue hypoxia remains despite mobilization of compensatory mechanism. Hypoxia is essential for initiation of adequate cardiovascular and erythropoietic compensation mechanism, but severe tissue hypoxia can cause the following symptoms: dyspnea, exhaustion, or even at rest, angina, intermittent claudication, muscular cramps, typically at night, headache, lightheadedness, and fatigue. A number of diffuse gastrointestinal symptoms are associated with anemia, but whether their symptoms should be attributed to tissue hypoxia, compensatory distribution of blood, or underlying cause of anemia is uncertain. There are several classifications of anemia, so let's start from pathological one. And by pathological anemia classification, it can be defined anemia due to blood loss, chronic and acute ones, anemia due to increased production of the red blood cells in case of deficiency anemias or bone marrow disease or infiltration, and anemia due to increased destruction, inherited or acquired one. Morphological classifications have divided anemia into micro, normo, and microcytic hypochromic anemia. The main advantages of this classification are that the classification is simple and based readily available red cell indices, for example, mean corpuscular volume and mean corpuscular hemoglobin concentration. The functional classification of anemia has three major categories. There are marrow production defects, red cell maturation defects, and decreased cell survival in case of blood loss or hemolysis. In the first branch point of the classification of anemia, reticulocyte production index is higher than 2.5, indicates that hemolysis is most likely. Reticulocyte production index below 2 indicates either a hypoproliferative anemia or maturation disorder. A hypoproliferative anemia is typically seen with a low reticulocyte production index together with little or no change in red cell morphology, and normocytic normochronic anemia. Maturation disorders typically have a slight to moderately elevated reticulocyte production index that is accompanied by either microcytic or microcytic red cell indices. Increased red blood cell destruction secondary to hemolysis results in an increase the reticulocyte production index to at least 3 times normal, provides sufficient iron is available. Hemorrhagic anemias does not typically result in production indices of more than 2.5 times normal because of the limitation placed of expansion of the erythroid marrow by iron availability. According to the degree of severity, anemia can be classified as mild, moderate, or severe, while the mild anemia is defined by the levels of hemoglobin not below than 90 gram by liter, moderate from 90 to 70 gram by liter, and severe is less than 70 gram by liter or 7 gram by deciliter. The hematocrit is measurement of the volume of the red blood cells as a percentage of the whole blood. In the most anemic patients, blood hematocrit gives an excellent approximation of the total red cell mass and the functional estimation of the oxygen carrying capacity, whole blood viscosity. Immediately after blood loss, the hematocrit cannot be used as a reliable method to determine the quantity of the blood loss, because the patient loses plasma as well as red blood cells. After acute hemorrhage, the hematocrit falls within 48 hours until the plasma volume is replaced. At that time, anemia is normochromic and normocytic with normal cellular indices. Hematocrit levels that are too high or too low can indicate a blood disorder, dehydration, or other medical condition. The diagram on the left side of the slide illustrates that a person can have a low hematocrit and not be anemic, for example, in case of degradation. This occurs when a patient is overhydrated, typically as a result of over enthusiastic intravenous fluid therapy. In case of dehydrated patient, hematocrit will be increased as there is a loss of fluid part of the plasma despite normal levels of erythrocytes count. Iron deficiency anemia is defined as a decreased total iron body content. Iron deficiency anemia occurs when the iron deficiency is severe enough to diminish erythropoiesis and cause the development of anemia. It's the most prevalent single deficiency state on the worldwide basis. It's a disease potentially exposed to people at all ages, both sexes and socioeconomical classes and geographical regions. However, the most prone to this type of anemia are pregnant women, women of reproductive age, and children under school age. The patient with low socioeconomic status. According to the report of the WHO, anemia affects 1.6 billion people, accounting around 25% of the global population. The highest prevalence in the world have seen in Africa and Southeast Asia. In India, for example, up to 88% of pregnant and 74% of non-pregnant women are affected. Throughout Africa, about 50% of pregnant and 40% of non-pregnant women are anemic. West Africa is the most affected, and Southern Africa is the least one. There are 4 major types of causes that can lead to iron deficiency and appearance of anemia. First one is increased requirements of iron in case of, for example, pregnancy, lactation, or menstruating women, or growing of infants and children. The second one is decreased intake due to socioeconomic status, vegetarian diet, alcohol in elderly or ethnic different groups. Third one, increased loss of the iron in case of the menorrhagia, GI bleeding, blood donation, hemolytic anemia, extreme physical exertion. And the last one is decreased absorption due to dietary factors, gastrointestinal pathology, different one, medication with a decreased gastric acidity, duodenal pathology, or chronic renal failure. Iron is the vital for all living organisms because it's essential for multiple metabolic processes, including oxygen transport, DNA synthesis, and electron transport. The major role of iron in mammals is to carry oxygen as part of hemoglobin. Oxygen is also bound by myoglobin in the muscle. Iron is a critical element in iron-containing enzymes, including cytochrome systems in mitochondria. Iron absorbed from the diet or released from stores circulates in the plasma bound to transferrin, the iron transport protein. Transferrin is big-lobed glycoprotein with two iron binding sites. Transferrin carries iron exists in two forms, monoferric and diferric. Because almost all of the iron transported by transferrin is delivered to the erythroid marrow, the clearance time of transferrin-bound iron from the circulation is affected most by plasma iron level and the erythroid marrow activity. The iron transferrin complex circulates in the plasma until it interacts with specific transferrin receptors of the surface of the marrow erythroid cells. Once the iron-bearing transferrin interacts with its receptor, the complex is internalized via clathrin-coated pits and transported to an acidic endosome, where the iron is released at the low pH. The iron is then made available for heme synthesis, while the transferrin receptor complex is recycled to the surface of the cell, where the bulk of the transferrin is released back to circulation and transferrin receptor re-enters into the cell membrane. Iron is excess of the amount needed for hemoglobin synthesis binds to storage ferritin, forming ferritin. Once within the red blood cells, the digested hemoglobin is broken down, the globin and the proteins are returned to the amino acid pool, and the iron is shuttled back to the surface of red blood cell, where it's represented to circulating transferrin. Normally, an endowed male will need to absorb at least 1 milligram of elemental iron daily to meet needs, while females in the childbearing years will need to absorb an average 1.4 milligram per deciliter. The balance of iron in humans is tightly controlled and designed to convert iron for reutilization. There is no regulated excretory pathway for iron, and the only mechanism by which iron is lost are blood loss via gastrointestinal bleeding, menses, and other forms of bleeding, including hemorrhoids, and the loss of epithelial cells from skin, gut, and genitourinary tract. Normally, the only route by which iron comes to the body is via absorption from food or from additional iron taken orally. Iron may also enter the body through the red cell transfusion or injection of iron complexes. Iron absorption takes place largely in the duodenum and proximal small intestine, and is carefully regulated process. For absorption, iron must be taken by the luminal cell. That process is facilitated by the acidic content of the stomach, which maintains the iron in solution. At the brush border of the absorptive cell, the ferric iron is converted to the ferrous form by phaeductase, the enzyme. Once inside the gut cell, iron may be stored as ferritin and transported through the cell to be released at the basolateral surface to plasma transferrin through the membrane-embedded iron exporter, ferropoietin. The function of ferropoietin is negatively related by hepcidin, the principal iron regulatory hormone. The liver synthesis transferrin is secreted to plasma. Transferrin are produced locally in the testes and certain nervous system. The two sites are relatively inaccessible to proteins in the general circulation due to the presence of blood testis and blood-brain barriers. When bound to iron, it's known as apotransferrin. Each transferrin molecule has the ability to carry two ions in the ferric form. The transferrin binds to transferrin receptor on the surface of the cell, then it transported into the cell in a vesicle by receptor-mediated endocytosis. The pH of the vesicle is reduced by hydrogen ion pumps to about 5.5, causing transferrin to release its ions. The receptor is then transported through the endocytic cycle back to the cell surface, ready to another round of ion uptake. Ferritin is a global protein complexes consisting from 24 protein subunits in the primary intracellular iron storage protein, keeping iron in a soluble state and non-toxic form. Ferritin not combined with iron is called apoferritin. Each ferritin complex can store about 4,500 ions. The heavily chain of ferritin also possesses a ferroxidase activity. This involves the conversion of iron from ferrous to ferric state. This limits the deleterious reaction which occurs between ferrous ion and hydrogen ion. Fenton reaction can produce the highly damaging hydroxyl radical. Iron deficiency anemia often develops gradually with small amounts of blood loss. Such person may remain asymptomatic until their iron stores become sufficiently depleted to compromise red cell production and other tissues, at which point fatigue and other symptoms arise. The one half of the patient with moderate iron deficiency anemia develop pathogenetic. Usually they crave ice to suck or chew. Occasionally patients are seen who prefer cold celery or other cold vegetables in lieu of ice. Leg cramps, which occur on climbing stairs, also are common in patients with deficiency of iron. Fatigue and diminished capability to perform hard labor are attributed to the lack of circulating hemoglobin. However, they occur out of proportion to the degree of anemia, probably due to a depletion of proteins that require iron as the part of their structure. Dietary history is important. Vegetarians are more likely to develop iron deficiency unless their diet is supplemented with iron. Bleeding is the most common cause of iron deficiency, either from parasitic infection or other causes of the blood loss. With bleeding from the most orifices, patient will present before they develop chronic iron deficiency anemia. However, gastrointestinal bleeding may go unrecognized. Patients often do not understand the significance of melatonic stool. Excessive menstrual losses may be overlooked too. 3 pathogenetic mechanisms contribute to the anemic syndrome. First one, hemic hypoxia, refers to the decreasing amount of hemoglobin in the blood. Tissue hypoxia, which is the reduction of oxygen supply to a tissue below the physiological levels despite adequate perfusion of the tissue by blood, and decreased viscosity of the blood with appearance of systolic murmurs or breaths at eyes or noise in the jugular vein. Anemic syndrome represented by respiratory system is represented by dyspnea. Cardiovascular problems in patients with anemia will be represented with the heart pain, palpitation, or the heart failure. Central and peripheral nervous system reacts as feeling of the lack of air, fatigue, headaches, daytime sleepiness, dizziness, and fainting. Skin mucosa is usually pale due to hypersensitivity to cold and chilliness. Skeletal muscles represented by the changes represented by the symptoms as weakness and fatigue during exercise. Due to vasoconstriction of the arterioles of the skin and mucous membranes, paler skin, palmar crease, and conjunctival appears. On these pictures, you can see pale conjunctiva and not of the color of the pale anterior rim, and the posterior part of the conjunctiva are the same. Sideropenic symptom can be represented by epithelium of the skin and skin appendages changes and represented by dry exfoliating itchy skin, tendency to crack skin, poorly healing wounds of injuries, angular stomatitis, fragility, loss, early graying of the hair, thinning, brittle, dull nails, colonychia. The epithelium of lining mucosa changes is represented by sideropenic dysphagia, atrophic glossitis or gastritis, or rhinitis, or general atrophy of the intestinal mucosa. Bone marrow cells represent Dermatologic syndrome as decreasing the amount of hemoglobin in the RBC, decreasing the amount of RBC, reduction of phagocytic activity of neutrophils, or reduced number of T lymphocytes and reduction of their function. Specific symptom of Dermatologic syndrome is Picachloretica. Taste perversion characterized by an overwhelming desire to eat inedible, like chalk, clay, sand, ice, salts, etc. Manifestation of the symptoms includes Dermatologic perversion of smell or addiction to smells, which is the most others are perceived as unpleasant. The term pica comes from Latin pica, magpie, a bird known for its indiscriminate eating habits, and it's believed that terms were the first introduced by Byzantine physician Aetius or Famide in the 6th century, and in his book of obstetrics. One should note that pica in the most cases is a manifestation of iron deficiency, but sometimes it's a manifestation of zinc deficiency or mental disorders. With Dermatologic syndrome, also can be associated with dysphagia due to upper esophageal webs, or iron deficiency anemia not associated with anemia itself. The presence of mucous membranes in webs in the upper third of the esophagus you can see on this slide. Angular cheilitis is an inflammatory lesion, the labial commissure on corner of the mouth, and often occurs bilateral. The condition manifests as a deep crack and splits. Cheilitis is a medical condition with inflammation of the lip together. Glossitis in inflammation of the tongue. Koilonychia, also known as spoon nails and nail disease, can be a sign of hypochromic anemia, especially iron deficiency anemia. It refers to abnormally thin nails which have lost their convexity, becoming flat and even concave in shape, as you can see in pictures. Another presentation of Dermatologic syndrome is poorly healing wounds and injuries, dry exfoliate in each skin. There are three major stages of iron deficiency, which has names: pre-latent iron deficiency with depleted iron stores, latent iron deficiency, and iron deficiency anemia, represented by low hemoglobin, and features of first and second stages plus anemia. In first stage, pre-latent iron deficiency, depleted iron stores, but increased iron absorption and normal serum iron capacity to bind iron and transport to it around the body. In latent iron deficiency, there are decreased iron status levels, and there is an increase in the capacity of the binding and transporting iron. The CBC documents the severity of anemia. In chronic iron deficiency anemia, the cellular indices show microcytic and hypochromic erythropoiesis, that is, both the mean corpuscular volume and the mean corpuscular hemoglobin concentrations have values below the normal range for the laboratory performance of the test. Often the platelet count is elevated. This activation normalizes after iron therapy, while white blood cells count is usually within normal ranges, but it may be elevated. Low serum iron and ferritin levels with elevated total iron binding capacity are diagnostic of iron deficiency, while low serum ferritin is diagnostic of iron deficiency. Normal ferritin can be seen in patients who are deficient in iron and have coexisting diseases. The examination of porcine blue-stained bone marrow aspirate for the presence of or absence of histiocytic iron granules has been considered to the gold standard, and appears in variously sized intracellular blue granules and widely uniform intracellular deposits. The complete absence of staining is considered to represent iron deficiency. Investigating the loss of iron by staining the urine sediment for iron, hemosiderin is detected intracellularly, and most of these patients have a low or absent plasma haptoglobin. Please pay attention that there are several changes of the transferrin and serum iron that can be significant for diagnosis of anemia. Examination of the peripheral smear is an important part of the workup of patients with anemia. Examination of the erythrocytes shows microcytic hypochromic red blood cells and chronic iron deficiency anemia. The microcytosis is apparent in the smear long before the mean corpuscular volume is decreased after an event producing iron deficiency, and platelets usually are increased in that disorder. The iron deficiency anemia, like thalassemia, tucked cells usually are not present, and anisocytosis and poikilocytosis are not marked. This condition lacks to intraerythrocytic crystals seen in hemoglobin C disorders. Microcytosis with hypochromasia, hypochromic and microcytic red blood cells are seen on this picture, with occasional target cells. The small mature lymphocyte can be used to size the red blood cells. Many of the red blood cells have increased central pallor, which has a name hypochromia. Three main strategies can be applied in order to improve iron status in individuals and populations: dietary modification, food fortification, and iron supplementation. Medical care starts with establishing the diagnosis and the reason for the iron therapy. Dietary iron sources include meat, fish, and poultry, lentils, dry beans, grain products, vegetables, dry fruits, and molasses. There should not be taken soy protein, type of teas, coffees, or phosphate, allowing the patients to receive their good food. In any case, the treatment guidelines from the American College of Physicians for adult patients with anemia and iron deficiency include the following: restrictive red blood cell transfusion strategies recommended for hospitalized patients with coronary heart disorder, with the trigger hemoglobin thresholds over to 7 to 8 grams by deciliter. Erythropoiesis-stimulating agents are not recommended for patients with mild to moderate anemia and either congestive heart failure or coronary heart disease. Oral ferrous iron salts is the most economical and effective medication for the treatment of iron deficiency anemia. Of the various iron salts available, ferrous sulfate is the one most commonly used. Also, the traditional dosage of ferrous sulfate is 325 milligrams orally 3 times a day. Lower dosage may be as effective as cause fewer effects. To promote absorption, patients should avoid tea and coffee and may take vitamin C with iron pill once daily. Receive parenteral iron for patients who are either unable to absorb iron or have increased anemia, despite adequate doses of oral iron. It's expensive and has great morbidity than iron preparation can taken orally. Parenteral iron has been used safely and effectively in patients with cerebral bowel syndrome, in whom ferrous supplementation with iron sulfate induces hepcidin increase up to 48 hours, limiting the absorption of subsequent dosages. Prophylactic treatment with iron sulfate has been recommended in rural areas characterized by high prevalence of iron deficiency anemia. There are several side effects of oral iron intake, as iron supplements can cause gastrointestinal Side effects as gastric discomfort, nausea, vomiting, constipation, and diarrhea. The frequency of the side effects is directly related to the dose of iron and percentage of elemental iron in the tablet. The iron consumed with the meal is better tolerated than it taken on empty stomach. Also, the amount of iron absorbed is reduced. Also, blackening of teeth and feces may occur due to formation of the iron sulfide and metallic state. After aspirin, the second commonest cause of accidental poisoning among the small children is iron. Most deaths occur in children, particularly from 20 to 14 months old, which can cause a death in case of taking of 1 or 2 grams of iron. The colored sugar coating of many commercially available tablets may attract the child and he may consume them. Established indication to intravenous iron or reduced subscription capacity in the presence of gastrointestinal disorders and bariatric surgery, severe anemia, high hepcidin resulting from concomitant inflammation, and rarely then a fast recovery is desirable. Advantage is the more rapid effects and then negligible gastrointestinal toxicity. Intravenous iron is available in different forms. Iron gluconate and iron sucrose require a repeated infusion with ferric carboxyl maltose, ferrum xylitol, low molecular weight iron dextran, and iron isomycetoside may be administered in high dosages to replace the total iron deficit in 1 or 2 infusion. B12 deficiency anemia. The term pernicious anemia is an anachronism and dates from the era when treatment had not yet been discovered and the disease was fatal. But it remains in use for megaloblastic anemia resulting from vitamin B12 deficiency due to lack of intrinsic factor. Thus, pernicious anemia must be differentiated from other disorders that interfere with absorption and metabolism of vitamin B12. Megaloplastosis describes a heterogeneous group of disorders that share common morphological characteristics. Large cells with an arrest in nuclear maturation. Nuclear maturation is a measure relative to cytoplasmic maturity, hence the cells which can be seen in bone marrow aspirates and in peripheral smears have been called megaloblasts. These abnormalities are due to impaired DNA synthesis and, to a less extent, RNA and protein synthesis. Megaloblastosis can be associated with severe anemia and pantocytopenia, gastrointestinal dysfunction, and myositis, personality changes, psychosis, and neurological disorders. Vitamin B12 and folic acid deficiency and certain medication are the most common causes of megaloblastic anemia and macrocytic anemia. Megaloblastic anemia usually appear due to folate deficiency, cobalamin deficiency, and anti-folate drugs regimes. Microcytic anemia is usually anemia due to liver diseases, reticulocytosis, myelodysplasia, alcoholism, or hypothyroidism. Let's see the distinction between microcytic anemia and megaloblastic anemia is critical. In microcytic, there are many erythrocytes with small size and hyperchromatic. In patients with megaloblastic anemia should be seen not only erythrocytes with bigger size than usual one, but presence of hypersegmented neutrophils and different microvallocytes or teardrop cells. The adult form of pernicious anemia is most prevalent among individuals in either Celtic or Scandinavian origin, pernicious anemia reported less commonly in people of other racial backgrounds. Also, the disease was once believed to be rare in Native American people and uncommon in Black people. Adult pernicious anemia usually occurs in people aged 40 to 70. Male predominance has been reported in England, Scandinavia, and African descent persons. After indigestion, the low stomach pH cleaves cobalamin from other dietary protein. The free cobalamin binds to gastric air binder, a glycoprotein in saliva, and the complex travels to the duodenum and jejunum, where pancreatic pancreatides digest the complex and release cobalamin. Free cobalamin can then bind with the gastric enteric factor and glycoprotein produced by the gastric parietal cells, the excretion of which parallels that of hydrochloric acid. Only 99% of undigested cobalamin requires enteric factor for absorption. Up to 1% of free cobalamin is absorbed passively in the terminal ileum. Once bound to enteric factor, vitamin B12 is resistant to further digestion. The complex travels to distal ileum and binds to a specific mucosal brush border receptor, Cobalamin, which facilitate the internalization of cobalamin enteric factor complex in an energy-dependent process. Once internalized, the enteric factor is removed and cobalamin is transferred to other transport protein, transcobalamin 1, 2, 4, and 3. 80% of cobalamin is bound to transcobalamin 1 or 3, whose role in cobalamin metabolism whose role is unknown. The other 20% binds with transcobalamin 2, a physiological transport protein produced by endothelial cells. Its half-life, up to 9 minutes, as delivery to target tissue is rapid. The cobalamin transcobalamin 2 complex is secreted into the portal blood, where it's taken mainly in the liver and bone marrow, as well as other tissues. Once in the cytoplasm, cobalamin is liberated from the complex by lysosomal degradation. The enzyme-mediated reduction of the cobalt occurs by cytoplastic methylation to form methylcobalamin or by mitochondrial adenosylation to form adenosylcobalamin and two metabolic active forms of cobalamin. In the cytoplasm, methylcobalamin serves as cofactor for methionine synthesis by ion transfer of methyl group from 5-methyl tetrahydrofolate to homocysteine, forming methionine and demethylated tetrahydrofolate. After conversion to its polyglutamate form, tetrahydrofolate participates in purine synthesis and DNA synthesis. Because folate deficiency causes microcytosis and cytonuclear dissociation via the same mechanism, both deficiency lead to megaloblastic anemia and deteriorate maturation in granulocytic lineage. Therefore, folate supplementation can reverse the hematologic abnormalities of vitamin B12 deficiency, but has no effect on neurological abnormalities of vitamin B12 deficiency. Vitamin B12 influences and regulates the creation and maintenance of the myelin sheath through the 4 different mechanisms. Adenosylcobalamin required for the formation of lipids and proteins from which myelin is created, lowers the level of amino acids which are probably neurotoxic, works like a hormone in the central nervous system and regulates the level of important cytokines and neurotrophic factors, is a crucial antioxidant in the central nervous system and through different mechanisms protects the nerves from chronic inflammation, reactive oxygen, and nitrogen radicals and toxins. Methylcobalamin is required for the creation of adenosylmethionine, the most important methyl donor in the human body. This substance is needed for the methylation of the myelin-based protein, which plays a central role in the creation of the myelin. Methylcobalamin also promotes the formation of phosphatidylcholine, lecithin, an important component in myelin sheaths. Methylcobalamin lowers level of homocysteine, which is suspected of having direct neurotoxic properties. And B12 vitamin regulates the level of certain neurotrophic factors such as neurotransmitters, growth factors, and so-called cytokines, essential messenger substances. Cobalamin deficiency may result from the following: inadequate dietary intake, atrophy or loss of gastric mucosa, functional abnormal enteric factor, inadequate proteolysis of dietary cobalamin, insufficient pancreatic protease, bacterial overgrowth in intestine, Diffilobacterium mulatum competes with the body for cobalamin. It's a fish type worm. Disorders of ileal mucosa, different one. Disorders of plasma transport of cobalamin. Dysfunctional uptake and use cobalamin by cells. Increase in incidence of pernicious anemia in families suggests a hereditary component to the disease. Patients with pernicious anemia have increased incidence of autoimmune disorders, and thyroid disorder suggests that the disease has an immunological component. Dietary cobalamin is acquired mostly from meat and milk and is absorbed in the series of steps which require proteolytic release from foodstuff and binding to enteric factor. Classic pernicious anemia produces cobalamin deficiency due to a failure of the stomach to secrete enteric factor. Antiparietal cell antibodies cure 90% of patients with pernicious anemia, but in only 5% of healthy adults. Similarly, binding and blocking antibodies to enteric factor are found in most patients with pernicious anemia. In adults, pernicious anemia is associated with severe gastric atrophy and achlorhydria, which are irreversible. Coexistent iron deficiency is common because achlorhydria prevents solubilization of dietary ferric iron from foodstuff. Autoimmune phenomena and thyroid disease frequently observed. Patients with pernicious anemia have 2 to 3-fold increased incidence of gastric carcinoma. A patient history might reveal manifestation of anemia and neurological abnormalities. Since anemia develops insidiously, patient may be virtually asymptomatic. However, those with severe anemia may experience weakness and cardiopulmonary impairment. Element complexation occurs due to intramedullary hemolysis. Some patients can have gastrointestinal signs and symptoms such as loss of appetite, weight loss, nausea, and constipation. Patient may have a sore tongue and canker sores. The spectrum of mental changes from a change in personality to psychosis, as well as peripheral neuropathy, can occur in postfolate and cobalamin deficiency. Peripheral neuropathy presents as numbness, pain, tingling, and burning in the patient's hands and feet. Patient may report small loss of sensation and that they feel like they are wearing a thin stocking and glove. Some patients with cobalamin deficiency can present primarily with neurological impairment and are not anemic. Neurological symptoms may range from mild to severe. Cobalamin deficiency should be considered even if patient has minimal neurological symptoms and is not anemic. History findings to help identify cobalamin deficiency are as follows. Evidence of achlorhydria such as abdominal discomfort, reflux, early satiety, and abdominal bloating. Pernicious anemia. Family history of a gastrectomy, conditions that affect the terminal ileum, such as inflammatory bowel disease, for example, condition in which cobalamin is competitively consumed in case of different parasitic infection or abdominal surgery, Zollinger-Ellison syndrome or pancreatic insufficiency due to problem with binding of to enteric factor, strict vegetarian, with no consumption of eggs and dairy products, history of late administration without B12, and history of megaloplastosis since childhood. Historic findings to help identify folate deficiency are follows: poor nutrition, alternative diets, and excessive heating and dilution of foods, chronic alcoholism, conditions that interfere with folate absorption, including inflammatory bowel disease, gluten sensitivity, and amyloidosis, conditions that increase folate consumption, aspiration, pregnancy, lactation, hematopoietic anemia, etc. Hyperalimentation and hemodialysis medication that affects folate and had different hereditary disorder. Evidence of anemia represented by dyspnea, tachycardia, and cardiopulmonary cases, distresses in severe cases, but patient can be unsymptomatic if anemia had developed gradually and was compensated. Patient may have a lemon yellow hue due to the combination of anemia and increased indirect bilirubin level. The source of the bilirubin is intramedullary hemolysis. Glossitis characterized by smooth tone due to loss of papilla occurs in person with cobalamin deficiency. Dermatologic signs include hyperpigmentation of the skin and abnormal pigmentation of hair due to increased melatonin synthesis. Infantile vitamin B deficiency is common to underdeveloped countries and associated with hyperpigmentation of the dorsa of the hands and feet, as well as generalized hyperpigmentation. The wide range of mental changes from irritability to psychosis, as well as peripheral neuropathy, can occur in both folate and cobalamin deficiency. Subacute combined neurologic degeneration occurs in cobalamin deficiency. Patient present with abdominal gait, loss of balance, speech impairment, loss of proprioceptive and vibratory senses, blindness due to an optic atrophy may occur. Abdominal scars may suggest a blind loop syndrome due to a gastric surgery or lack of the ileal absorption of cobalamin in a patient who had an ileal resection. Patients with non-tropical and tropical sprue may have signs of malabsorption, such as weight loss, abdominal distension, diarrhea, and steatorrhea. These patients often have metabolic bone disease and bleeding resulting from deficiency in vitamin K dependent factors. Initial workup for megaloblastic anemia should include the following assays: CBC, RBC indices, peripheral blood smear, reticulocyte count, lactate dehydrogenase levels, and direct bilirubin, iron and ferritin levels, serum cobalamin, serum folate, and possibly red blood cells folate levels. The level of lactate dehydrogenase is usually marked increase in the several megaloblastic anemia. Reticulocyte counts are inappropriately low, resulting in lack of production of red blood cells due to massive intramedullary hemolysis. These findings are characteristics of ineffective hematopoiesis that occurs in megaloblastic anemia as well as in other disorders such as thalassemia major. Peripherals may reveal macroovulocytes, characteristic of megaloblastosis. They should be distinguished from macrocytes that are not oval, which can occur in liver disease and hypothyroidism. Polychromatophilic macrocytes, reticulocytes, and immature red blood cells can be seen in hemolytic anemia and disorders associated with increased RBC production. Single and multiple halotype bodies, nuclear fragments may be seen in red blood cells. Cabo rings, a remnant of mitotic spindles, may also be present in red blood cells. Nucleated red blood cells and megaloblast can be seen. Smears may reveal hypersegmented neutrophils if at least 5% of neutrophils have 5 or more lobes, and normal neutrophils contain 3 to 4 lobes. Macrocytosis due to cobalamin or folate deficiency may be masked in patients with iron deficiency. However, hypersegmented neutrophils can persist in iron deficiency. Microcytosis of mean corpuscular volume more than 100 with or without anemia is a common finding in adults undergoing automated complete blood counts. Patients with elevated mean corpuscular volume may have a megaloblastic disorder defined by presence of morphologic states in the bone marrow that reflect the defective DNA synthesis or non-megaloblastic disorder. The presence of megaloblastic changes in the marrow usually implies a diagnosis of cobalamin or folate deficiency. However, some myelodysplastic disorders are associated with the similar morphological changes. In patients with either cobalamin or folate deficiency, the muscular volume tends to increase before the hemoglobin level decreases significantly. However, even when there is biochemical evidence of vitamin deficiency, the mean corpuscular volume often remains within the reference range, especially if concurrent deficiency of thalassemia is present. This parameter also lacks specificity for the diagnosis of cobalamin or folate deficiency. Bone marrow aspiration is usually not needed to make diagnosis of B12 deficiency. However, it can help rule out the myelodysplasia and assess iron source. The bone marrow is hypercellular with erythroid hyperplasia. Erythroid precursors have megaloblastic features, being larger than normoblastic cells, pointed by arrow. And in addition, nuclear maturation is a mature relative to cytoplasmic maturation. Megaloblastic changes are most prominent in more mature RBC precursors. Giant bands neutrophil precursors can be present. Megakaryocytes may be large and hyperlobulated. There are several tests for vitamin B12, serum folate, RBC folate that can be used to elevate the levels of these active substances. Serum folate levels decrease with a few days of dietary folate restriction. Also, tissue stores may be normal. Folate concentration within erythrocytes are much higher in the serum, and even a slight degree of hemolysis will cause a falsely elevated serum folate level. Patients were considered to be cobalamin deficient if they had characteristic clinical features that responded to cobalamin therapy. Also, for some patients, follow-up data is not accessible after therapy or lacking. Lab test to confirm and distinguish B12 and folate deficiency includes several ones: the use of metabolite measurement for diagnosis, confirmation, differentiation of this deficiency has been made possible by development of accurate assays for serum urine. As discussed previously, elevation of both metabolite levels are anticipated in patients with cobalamin deficiency, whereas only hemoglobin levels would be expected to increase in patients with folate deficiency. If antibodies type 1 and type 2, interleukin factor antibodies to type 1 or type 2, or both together, occurs in 50% of patients with pernicious anemia and specified for this disorder. Therefore, they can be used to confirm the diagnosis of pernicious anemia. Parietal cell antibody occurs in 90% of patients with pernicious anemia, but also occur in thyroid disease and other autoimmune disorders. Schilling test is no longer available for testing and confirmation of B12 deficiency, which allows to distinguish pernicious anemia and ferritin transport or ileal uptake. Unfortunately, the test is no longer available in the most hospitals. Baseline iron studies and serum ferritin should be obtained since they may predict the need of the iron therapy, since iron stores can be consumed during cobalamin and folate therapy. A radiographic imaging of the upper and lower gastrointestinal tract may be useful for detecting abnormalities that could cause a blind loop syndrome. This procedure may detect defects in the terminal ileum that might interfere with cobalamin absorption. Other tests that may be considered include the following: with cobalamin deficiency, evaluate and rule out autoimmune disorders, Zollinger-Ellison syndrome patient, pancreatic insufficiency, fish tapeworm infestation, Crohn's disease, or ileum scarring. With folate deficiency, evaluate evidence for malnutrition and alcoholism, spur chronic hemolysis, and exfoliative dermatitis, and megaloblastic anemia. If we compare cobalamin and folate deficiency, we will see that the difference is in folate levels. In folate deficiency, of course, increased. In cobalamin deficiency, normal, it tends to increase, but serum methylmalonic acid is increased in megaloblastic, but decreased in folate deficiency anemia, as all others parameters except serum B12 and folate levels are the same. Patients should have diet rich with folic acid. Examples of such food includes asparagus, broccoli, spinach, lettuce, lemons, banana, etc. To prevent loss of folate, food should not be cooked extensively and should not be diluted in a large amount of the water. To prevent cobalamin deficiency, vegetarians should include dairy products and eggs in their meal. The hematologist should be consulted to assist with the diagnosis and management of the anemia, neurologists for consultation and treatment of neurological complications, and gastroenterologists should be consulted since an endoscopy may be indicated to rule out atrophic gastritis and to evaluate patients for gastric carcinoma with periodic endoscopy. Cobalamin should be given intramuscular daily for 2 weeks, then weekly until the hematocrit value is normal, and then monthly for life. A dose of 1,000 nanograms is large, but it may be required in some patients. Oral cobalamin also can be administered. It's less expensive and better tolerated by patients. Patients who have undergone either total or partial gastrectomy should be started on replacement therapy after the surgery to prevent the development of megaloplastosis. Oral dosages should be monitored for the desired response, since absorption can be variable and may be insufficient in some patients. Oral cobalamin is indicated in patients with hemophilia to avoid bleeding during injection. Intramuscular cobalamin and oral cobalamin should be used to treat patients with cobalamin-related neurological disorder. One advantage of parenteral oral cobalamin is not that all abnormalities in cobalamin absorption are bypassed. It may be practical to administer parenteral cobalamin initially and then switch to oral cobalamin. PPI, H2 receptors, and metformin may reduce serum level of B12 concentration and by inhibiting of absorption of vitamin B12. Folate should be administered orally. If this is difficult, comparable dosage can be administered parenterally. In addition, the patient should consume a folate-enriched diet. Also, folate should be administered prophylactically during pregnancy, lactation, and the perinatal period. Folate indicated in patients with chronic hemolytic anemias, psoriasis, exfoliative dermatitis, and other extensive renal dialysis. Had been recommended in patients with hyperhomocystinemia who are at risk of their problems. Fortification foods and folic acid supplements have been recommended to reduce the risk of pancreatic, cervical, and colon cancers. Also, patient may feel better as soon as therapy started. Improvements must be monitored with CBC, reticulocyte count, LDH level, interacted bilirubin, hemoglobin level, serum potassium level, and serum ferritin level. Reticulocytosis should be evident with 3 to 5 days and peaks to 4 to 10 days. Hemoglobin should rise approximately 1 gram by deciliter. And this rise is available for monitoring and complete response. As discussed above, patients with cobalamin deficiency may have overt neurological disease in the absence of hematological findings, and patients with neurological symptoms and signs are and a normal complete blood cell count require a modified diagnostic approach because of several considerations. First, folate deficiency are unlikely cause of neurological disease. Second, the neurologic disease of cobalamin deficiency may be reversible if treatment is withheld or delayed. Because cobalamin therapy is non-toxic, a risk-benefit ratio favors treatment in questionable cases. Finally, an apparent response to therapy is less definitive in ruling out or ruling in cobalamin deficiency than in the serial measurement and abnormal initial hematological parameters. Even in patients with normal complete blood count, it may be worthwhile to monitor the mean corpuscular volume after treatment because of significant decline within the normal range provides additional evidence of cobalamin deficiency. The following goals are the most important in establishing care for patients with pernicious anemia. So they are to establish that the patient has cobalamin deficiency if no evidence for folic deficiency, but pernicious anemia has not been ruled out. Treat the post-folic and cobalamin until pernicious anemia has been ruled out. To determine the cause of the failure to absorb cobalamin, not all hematologists work to establish the precise cause of low vitamin B12 levels, to treat the patient with adequate dosages of cobalamin, to confirm the diagnosis by documenting that specific therapy is effective, and to assure administration of adequate quantities of cobalamin for the lifespan of the patient. Once therapy is started, hospitalization is necessary only for patients with severe life-threatening anemia. The term of anemia of chronic disease or anemia of chronic disorder refers to mild to moderate severe anemia associated with chronic infection and inflammatory disorder and some malignancies. The new name, anemia of inflammation, is not only more reflective for the pathophysiology of this anemia, but also includes anemia of critical illness, a condition that presents similarly to anemia of chronic disease, but develops within days and the onset of illness, and anemia is similar to this one is seen in some older individuals in the absence of identifiable chronic disease. This condition is sometimes referred to as unexplained anemia of elderly and or anemia of aging. This anemia is characterized by inadequate erythrocyte production in the setting of the low serum iron and low iron binding capacity despite preserved or even increased macrophage IgG stores in the marrow. The erythrocytes are usually normocytic and normochromic, but can be mildly hypochromic and microcytic. Anemia of critical illness can develop acutely within days in intensive care, where the effect of infection or inflammation exacerbated by decreased related or iatrogenic blood loss or red cell destruction. Anemia of aging is diagnosed in the older than normocytic normochromic anemia with low serum iron and presented iron shorts developed without an identified underlying disease. Older patients in this defined subset typically have an elevated sedimentation rate or elevated CRB, a high plasma interleukin concentration for interleukin-6 and frailty. Anemia of chronic disease is characterized primarily by decreased availability of iron, relatively decreased levels of erythropoietin, and mild decrease in the lifespan of red blood cells, up to 18 days instead of 120. Hepcidin and endogenous antimicrobial peptides secreted by liver have been identified as controlling the level of plasma iron by regulating the intestinal absorption of dietary iron, as well as the release of iron from macrophages and transfers of iron stores in hepatocytes. Increase of hepcidin level in course of an inflammatory disease may be significant mediator of the accompanying anemia. Another proposed mechanism for anemia of chronic illness involves cytokines such as interleukins 1 and 2 and tumor necrosis factor alpha. They are believed to cause the destruction of red blood cells precursors and to decrease number of erythropoietin receptors on progenitor cells. The severity of anemia is directly related to the degree of loss of kidney function, as kidneys are responsible for 90% of erythropoietin production. Whereas hypoxia in an individual with normally functioning kidney leads to erythropoietin gene expression and then increased RBC production. Chronic kidney disorder results in primary deficiency of erythropoietin production by the interstitial fibroblasts, also known as type 1 interstitial cells. In individuals with advanced stages of chronic kidney disorder, the etiology of anemia tends to be multifactorial and include the following: decreased red blood cell production due to lack of erythropoietin and iron deficiency, increased red blood cell destruction due to hemolysis, and increased blood loss due to multiple venipunctures for an array of indications. Patients with anemia of chronic disease may be present with the following symptoms: generalized weakness or malaise, generalized body aches, myalgia, orthostatic symptoms, syncope, near ones, decreased exercise tolerance, chest discomfort, palpitation, cold intolerance, sleep disturbances, inability to concentrate, and loss of appetite. The following physical findings may be noted: paler skin, decreased cognitive ability, pale conjunctiva, orthostatic hypotension, tachyarrhythmias, tachypnea, ascites, hepatosplenomegaly. The following laboratory tests are vital in the evaluation of anemia of chronic illness or chronic kidney disease. It's red blood cell indices, peripheral blood smear, and reticulocytes count. Laboratory tests that may help eliminate other common causes of anemia include iron panel, serum vitamin B12 and folic acid levels, serum bilirubin, AST/ALT, TSH or thyroid stimulating hormone levels, electrophoretic status of serum and urine, and serum levels of heavy metals. Measurement of serum erythropoietin levels is of no current diagnostic utility in patients with chronic kidney disease, as it is expected to be low. Neither does it influence the starting dose or any adjustment in dosing of erythropoietin-stimulating agents in such patients. Low reticulocyte count usually points to decreased red blood cells production as the primary mechanism responsible for anemia, whereas an elevated reticulocyte count points to increases red blood cell destruction or hemolysis as the most likely cause. The preferred initial therapy for anemia of chronic kidney disease or chronic disorder is the use of erythropoietin-stimulating agents. To evaluate response to these agents, many guidelines recommend measuring hemoglobin at least monthly during the initiation phase. During the maintenance phase, measurement is recommended at least every 3 months in patients with non-dialysis dependent kidney disorder and at least monthly in patients with last stages of kidney failure. As noted above, iron deficiency is the most common undetectable cause of erythropoietin agent resistance. The two most important tests to order to assess iron deficiency are transferrin saturation and serum ferritin. Anemia in these cases tends to primarily involve functional iron deficiency. Traditionally, this is characterized by less than 20% of decreasing of transferrin saturation and ferritin level less than 100 nanogram by milliliter. Clinician must also be aware that although the low ferritin level has high specificity to absolute iron deficiency, ferritin is an acute phase reactant that can be elevated in states of chronic infection or inflammation. Current guidelines recommended against the use of iron products when ferritin is 500 nanograms by milliliter or greater. The kidney disorder patient requires iron supplementation. IV iron is generally recommended, as IV iron consistently achieves higher transfer saturation at certain values than oral iron. An alternative to the administration of exogenous erythropoiesis stimulating agents is the use of agents that stimulate endogenous erythropoietin production in renal and non-renal tissues. One class of investigational agents under development works to stabilize the hypoxia-inducible factor by inhibiting protein hydroxylase enzymes. Oral iron products may be also helpful for management of iron deficiency anemia in patients with chronic kidney disorders or chronic inflammatory disorders who are not on dialysis. Aplastic anemia is a syndrome of bone marrow failure characterized by peripheral pancytopenia and marrow hypoplasia. Also, the anemia is often normocytic. Mild macrocytosis can also be observed in association with stress erythropoiesis and elevated fetal hemoglobin levels. Etiology of aplastic anemia has many varieties, from autoimmune disorders, chemical exposure drugs, as for example antibacterial drugs, or alkylating agents. Also anti-epileptic, anti-thyroid drugs has the ability to cause aplastic anemia. Different hereditary problems, infections, idiopathic aplastic anemia after defects of acquired stem cell, presence of radiation or hypopituitarism, pregnancy, and other disorder. The injury to hematopoiesis observed in aplastic anemia has primarily been shown to be facilitated by an antigen-driven immune response, which may be related to the suspected etiological factor discussed previously. In fact, several pathophysiological pathways have been proposed to explain the pathological nature of the disease, but the greatest proportion of causes is hypothesized to be a result of uniform T-cell mediated autoimmunity and marrow destruction leading to defective and nearly absent hematopoiesis. Strong laboratory data suggests that suspected yet unidentified antigenic exposure leads to a polyclonal expansion of CD4 T cells dysregulation at the genetic level and ultimately an overproduction of pro-inflammatory cytokines such as interferon gamma as well as tumor necrosis factor alpha. Oligoclonal expansion of dysregulated cytotoxic CD8 T cells population has also been demonstrated. The clinical presentation of the patient with the aplastic anemia includes symptoms related to the decrease in the bone marrow production of hematopoietic cells. The onset is insidious, and the initial symptom is frequently related to anemia or bleeding. Salt fever or infection may be noted at presentation. Specific manifestations include anemia, which manifests as a pallor, skin, headache, palpitation, dyspnea, fatigue, or foot swelling, thrombocytopenia that may result in mucosal and gingival bleeding or particular rashes, and neutropenia that may manifest as a wart infection, recurrent injection, or mouth and pharyngeal ulceration. Physical examination may show signs of anemia and thrombocytopenia, where signs of infection are usually not apparent at diagnosis. The substance of patient with aplastic anemia present with jaundice and evidence of hepatitis. Findings of adenopathy or organomegaly should suggest an alternative diagnosis. In case of suspected aplastic anemia, look for patient physical stigmata of inherited marrow failure syndrome, such as following: abnormal skin pigmentation, short stature, renal, cardiac, or gastrointestinal abnormalities, microcephaly, macroophthalmos, hypogonadism, and skeletal abnormalities. Varying degrees of progressive cytopenia observed in the three hematopoietic lineages A reduction in platelet and leukocytes count may precede the fall of hemoglobin. Peripheral SME is remarkable except the presence of mild microcytosis. The degree of cytopenia is useful in assessing the severity of plastic anemia, and decreased reticulocyte count is a characteristic finding. The peripheral blood smear may be helpful in distinguishing aplasia from infiltrated disease causes. Teardrop cells, poikilocytosis, and leukoerythroblastic changes suggest an infiltrative process. Bone marrow biopsy is performed in addition to aspiration to assess cellularity quantitatively and qualitatively. Aspiration samples alone may appear hypocellular because of technical reasons, or it may appear hypocellular because of areas of focal residual hematopoiesis. By comparison, core biopsy better reveals cellularity. Thin biopsy at least 2 centimeters is essential to assess the overall cellularity and the morphology of residual hematopoietic cells and to exclude abnormal infiltrates. In anaplastic anemia, hypocellular marrow particles are observed. Patients with aplastic anemia require transfusion support until the diagnosis is established and the specific therapy can be instituted. The different guidelines recommends prophylactic transfusion in patients who has platelet count fall below the 999 by liter. However, it's important that transfusion be guided by the patient's clinical status and not by numbers alone. Infections are the major cause of mortality of the patient with aplastic anemia. Risk factors include prolonged neutropenia and indwelling catheters used for specific therapy. Fungal infection, especially those who, due to Aspergillus species, pose a major risk. Patients should maintain hygiene-induced infection risk. Also recommend prophylactic antibiotic antifungal agents for patients with those neutrophil count is below 0.2. Patient on immunosuppressive therapy should receive prophylactic antiviral therapy. Central venous catheter placement is required prior to hematopoietic cell transplantation. The following recommendations do not apply for patients with Fanconi anemia and other types of inherited marrow failure. Early studies of unrelated umbilical cord blood transplantation reported high graft failure rates. However, subsequent studies using condition regimens that include low dosage and high total body radiation added improvements in enrichment and overall survival. Immunosuppressive therapy using anti-hemocyte globin and cyclosporin is used as first-line therapy for patients with severe and very severe aplastic anemia who are over 50 years old and as a secondary line in younger patients. Immunosuppressive therapy is also recommended in patients with non-severe aplastic anemia who are transfusional dependent. A thrombopac or Promacta is an oral thrombopoietin receptor agonist that approved in 2014 for patients with severe aplastic anemia that failed to respond adequately to at least one prior immunosuppressive therapy. This medication probably acts in aplastic anemia by stimulating the small number of residual cells in this patient's bone marrow. Also showed benefit as a first-line therapy. The diet for the patient with aplastic anemia who has neutropenia, who is receiving immunosuppressive therapy, should be tailored carefully to exclude raw meats, the dairy products, or fruits and vegetables that are likely to be colonized by bacteria, fungus, and molds. The patient should avoid the activity that increases the risk of trauma during the period of treatment, at least. And menstruating women are also advised to be on hormonal treatment to avoid menstrual cycles that are likely to be heavy due to thrombocytopenia. Thank you very much for your attention and for presence during these lectures. As usually, if you have any question, please send me to my email or under the lecture in our Facebook page. And have a nice weekend. Goodbye and good luck.